Now let's talk about congestive heart failure. So the basic definition for congestive heart failure would be impaired pumping action of the heart and decreased myocardial contractility. We have the left and right side heart failure. We also have systolic and diastolic heart failure. When we talk about CHF, we also need to be familiarized with cardiac output. So basically, in congestive heart failure, the cardiac output is affected or impaired. We see decreased cardiac output in congestive heart failure patients. Congestive heart failure can result in decreased blood pressure, therefore decreasing blood flow, and decreasing tissue or organ perfusion. Again, perfusion means blood flow. So there's two sides of heart failure. You have the left side heart failure and you also have right side heart failure. Left side or left ventricular dysfunction, the way I like to remember it is it starts with an L, right? Left side and left ventricular, so it starts with L as well. Left ventricle and then lungs. So that starts with L too. So left side, lungs, you have a lot of lung-related symptoms. So this right here is actually, it's a very old picture or illustration of a patient experiencing left-sided heart failure. It's easy to remember this kind of picture. As you can see, left-sided heart failure, there's a lot of restlessness, paroxysmal nocturnal dyspnea, lung symptoms, elevated pulmonary capillary wedge pressure, and we have pulmonary congestion, which includes cough, crackles, wheezes, blood-tinged sputum, tachypnea, and then there's also some confusion, orthopnea, tachycardia, exertional dyspnea, fatigue, and cyanosis. But if you can see this picture right here, it's a picture of somebody with congestive heart failure with a left-sided heart failure showing a lot of pulmonary or lung symptoms. So etiology, common cause of left-sided heart failure. A very common one is CAD, MI, cardiomyopathy, valve disorders, and hypertension. The left ventricle fails, then the left atrium starts failing as well. Then we have a lot of congestion in the pulmonary vessels. Therefore, with all that fluid collection, a lot of our patients eventually will develop pulmonary edema, which explains the symptoms that the patients usually experience when they have left-sided heart failure. Again, these are the signs and symptoms. So for the mental status, there's restlessness, agitation, fearfulness, anxiety. On the cardiac aspect, we see tachycardia, blood pressure changes, and pulmonary, there's pink frothy sputum, respiratory impairment, and as mentioned earlier, difficulty breathing, congestion, cough, and then the skin. When we're assessing the skin, we can sometimes see paleness, skin is cool and clammy because of that decreased perfusion. Next, we're going to talk about the right-sided heart failure or the failure of the right ventricle. So right ventricular dysfunction. What helps me remember the difference between the left side and right side is, again, when I think of the left-sided heart failure, I think of lungs. So we have a lot of lung symptoms. And then the right side are the rest of the body. So right side, the rest of the body, in comparison to the L, which are a lot of it is pertaining to lung symptoms. So this image right here portrays a very classic look of a patient with right-sided heart failure. So what's going on with a patient with right-sided heart failure? If you can remember what I told you earlier, a lot of times we're showing signs and symptoms of heart failure based on what's going on with the rest of the body. So we have fatigue, peripheral venous pressure is increased. We have ascites, so we see it on the abdomen, enlarged liver and spleen. Sometimes they can have some pulmonary symptoms, but then a lot of their symptoms are more of like congestion in the rest of their body. So distended jugular veins, anorexia, and complaints of GI distress. Then they also have a lot of swelling. So a lot of times you will see that those patients with a CHF exacerbation with right-sided failure, they come to the hospital with severe edema on their extremities. And then dependent edema, so edema usually where the gravity goes, so it's usually in the lower extremities. So this is what right-sided heart failure typically looks like. So etiology of right-sided heart failure, just like left-sided heart failure, it happens secondary to CAD, after an MI, cardiomyopathy, and pulmonary disease or congestion. So sometimes that backs up and affects the rest of the system. And so what happens with right-sided heart failure is the right ventricle starts failing, and then followed by failure of the right atrium. And so when the right ventricle and the right atrium are not working well, fluid starts backing up in the systemic circulation or systemic veins. Therefore, we're seeing a lot of those congestion in the rest of the body. So the signs and symptoms would be peripheral edema, jugular vein distension or JVD, a lot of gastrointestinal tract or vascular congestion, hepatomegaly or the enlargement of the liver, and splenomegaly, enlargement of the spleen, because there's a lot of congestion in that abdominal area. So general treatment for CHF or congestive heart failure is 1, identifying or treating underlying etiology, oxygen therapy, also treating anxiety and depression, nutrition, so making sure that it's low in salt and with some fluid restrictions when indicated, and also eating calorie-dense food. Also manage fluids and electrolytes and follow daily weights. Definitely strict INOs or intakes and outputs. When it comes to labs, we monitor cardiac enzymes, CBC, hemoglobin and hematocrit or hemogram, and then BNP or brain natriuretic peptide, which is secreted by the cardiomyocytes or the heart muscles in the ventricles as a response from stretching caused by the increased ventricular volume. So for CHF, we see CHF exacerbation or acute CHF. There is an increase in BNP because of that overstretching of the ventricle. So pharmacologic treatment, if patient is experiencing pain, for acute pain management, we give them morphine when needed. Also fluid volume management, we use diuretic therapy, mainly loop diuretics and the potassium sparing diuretics. And we also aim to reduce afterload. So afterload reduction. Before we talk about ways to decrease or reduce the afterload, we want to make sure that you know what does it mean when we talk about afterload. So afterload is the resistance the left ventricle needs to overcome in order to pump blood, pressure against which the heart must work to eject blood during contraction. With decreased afterload, if the resistance is lower, then we have an increased blood ejection. The heart can actually pump more blood to the system. So for afterload reduction, the first line therapy for CHF or heart failure, the classes are ACE inhibitors and ARBs. We also use the beta adrenergic blockers. We also use alpha-1 and beta receptor blockers, and as well as calcium channel blockers, nitrates, and vasodilators. Patients with CHF are also often started or treated with platelet aggregation inhibitors. Examples of those would be aspirin and clopidogrel. So why would we want them to be on platelet aggregation inhibitors? The reason for that is the prothrombotic or hypercoagulable state. There's a lot of venostasis due to the high pressure, low flow state, and also immobility. They're at a higher risk of clotting, so therefore it is usually beneficial to start them on platelet aggregation inhibitors such as aspirin and clopidogrel or Plavix. In addition, you'll see that they're also often on anticoagulants. So what are the examples of anticoagulants? So we have warfarin and enoxaparin or Lovinop. Again, why would we want them to be on anticoagulants? And for the very similar reason why we want them to be on platelet aggregation inhibitor, it's because of prothrombotic or hypercoagulable state. There's a lot of venostasis due to the high pressures, the low flow, and in addition to that low mobility status of the patients experiencing heart failure. Next are drugs affecting myocardial contractility. An important drug that you guys have to remember is lanoxin or digoxin. This is from the oldest group of cardiac drugs, and it's no longer used as first-line drug. So digoxin or lanoxin, it's from the pharmacologic class of cardiac glycoside. The way it works, it inhibits sodium, potassium, and then ATPase pump, and thus increasing cellular sodium and calcium concentration. It increases the vagal tone, and it can be given both in PO or IV form. So this drug enhances myocardial contractility. So it helps with the pumping ability of the heart. So the therapeutic effects of digoxin or lanoxin is increased myocardial contractility, or it's also known as a positive inotrope. So if it increases positive, and an inotrope pertains to contractility. In addition, this medication decreases heart rate, therefore it is considered negative because it decreases, and chronotrope, which pertains to heart rate. So this is a negative chronotrope. Indications for digoxins, or reasons why we give patients digoxin: one is heart failure, some dysrhythmias, and then also for controlling resting heart rate. So some precautions when giving this medication include renal insufficiency or renal failure, especially with borderline hypokalemia, because low K or hypokalemia may cause digoxin toxicity. So it's very important to make sure that the K or potassium level is at a good range before we give this medication. Also, we have to take precaution with symptomatic bradycardia, as it can decrease heart rate. Some contraindications: increase serum drug levels. So if your digoxin levels increase, obviously, then you have to hold it. Also, with patients showing signs and symptoms of digoxin toxicity. And again, contraindicated in hypokalemia or low potassium levels. Also, it's contraindicated with certain dysrhythmias. Some side effects would include nausea, vomiting, cardiac dysrhythmia. So that's something that you have to remember with medications that are used to treat cardiac dysrhythmia. So they can treat cardiac dysrhythmias, but they can also cause cardiac dysrhythmias. In addition, sometimes some patients would complain about visual disturbances, such as seeing yellow halos, sometimes green, purple, and nursing actions. So nursing actions or nursing interventions, monitoring labs. So the therapeutic level, so we check for digoxin levels, and the therapeutic level, or the level wherein the medication is deemed to be effective, or that's where we want it to be, is at 0.5 to 2 nanograms per ml. And in addition to that, just based on what we talked about with precautions and contraindications, we want to monitor and make sure we check the serum K or serum potassium level before we administer digoxin. The goal is at least a normal, or 3.5 to 5 potassium milliequivalents per liter of potassium, because again, the decrease in potassium and even sometimes magnesium can increase the potential for toxicity when it comes to digoxin. Last but not the least, we also want to monitor the renal function. So renal function would include our BUN, creatinine, because decrease in the renal function can also cause toxicity. So when it comes to assessment, what are we assessing for? So when we're doing our physical assessment, we want to make sure that we assess for therapeutic effects. So are we achieving our goals? Are we decreasing the heart rate? Are the symptoms improving? And then also we want to assess for possible side effects. Are they experiencing new dysrhythmias? When it comes to patient education, again, we want to educate them regarding the drug dosing, possible side effects, making sure that they check the heart rate. So we as nurses as well, this is very important before we give digoxin, is to check our patient's heart rate for a full minute. Before we give digoxin, we need to be careful, especially in symptomatic bradycardia. So when the heart rate is low, then it is ideal to not give digoxin. And also another important piece of patient education is to have the necessary lab work done. So making sure that their digoxin levels are routinely checked, as well as the renal function and the potassium levels. Sometimes, unfortunately, overdose or toxicity can happen. What do we do in case of overdose or toxicity? We want to make sure we assess for those signs and symptoms. So signs and symptoms of toxicity would include bradycardia, headaches, dizziness, confusion, EKG changes. Sometimes we're seeing some new dysrhythmias. So the first thing to do
is stop the medication. So if you see any of those, then you want to stop the medication. Especially this medication cannot be dialyzed out. So we just need to treat it symptomatically. And the antidote. So we can give the antidote, and the antidote for digoxin is Digibind. So digoxin immune fab. So this is something that you have to know. And we recheck our digoxin levels, and it can be inaccurate for about 3 to 5 days afterwards. So again, when would you hold digoxin? So if you have an order for digoxin, what are the things that would warrant holding that medication or not giving it to your patient? Pay very close attention to signs and symptoms of toxicity, and if your patient's heart rate is less than 60. Some general nursing actions, physical assessment, including cardiac rhythms, and then patient signs and symptoms. We also want to make sure that we follow daily weights. We want to check the labs, including CBC, electrolytes, especially the potassium, renal function, and then also drug levels, and important patient education pieces such as education regarding the disease process, symptom management for heart failure, medications, diet, lab work, and when to seek medical follow-up. It is also very important to teach the patient how to check their own heart rate. So luckily, we have the technology nowadays, especially if they're able and they can afford it. A lot of our devices or gadgets can actually measure the heart rate. That's a very important education aspect.